Good.
Good morning. I am Crystal Donovan, and I am a licensed social worker. Happy Social Work Month, consultant and trainer, and I talk a lot about first episode psychosis. And we're just going to spend a few minutes this morning talking about how we can increase engagement and accessibility from the front desk to the C suite. Here are our objectives this morning. We want to recognize the relationship between trauma and psychosis, identify universal trauma informed values and principles, and describe strategies to engage participants living with psychosis. As I was preparing for this didactic, I was reading, I was studying, I discovered a range of statistics, a range of rationale for disengagement, and there really wasn't like a sweet spot. So, some of the reasons that individuals disengage from treatment was simply they didn't return from after that initial assessment. However, some of the reasons identified were they got a job, they enrolled in school. So there were a range of reasons. And I kept thinking, I started asking myself, what are we missing? And so as I continued my study, a couple things continued to come up. The environment, so how the environment impacts one's ability to engage and access service, but also trauma. Trauma consistently came up. And so, in regard to trauma and prevalence, when we're talking about individuals living with psychosis, research indicates there's a strong relationship between trauma related psychosis and vulnerability to psychotic disorders. 70% of individuals living with psychosis have experienced at least one traumatic event. And for those of us that have ever been in an outpatient setting, then we know that many participants have experienced a series of events. And also, which I did find was interesting, and something maybe I knew, but just want to reinforce, is that risk increases in a dose related pattern. So, yes, if there have been a series of events, then that can increase one's risk. But also, the severity of exposure is associated with traumatic stress and psychosis severity. So, in this particular study with Campo Dinko and their colleagues, they were talking to participants and providers. And so, when they asked the participants about their ability or space to be able to talk about their trauma experiences, their responses were no one is asking about trauma. I know you might be thinking, wait a minute, we do ask about trauma. We ask it at intake. And so, when probed a little further, the participants did say yes. During the initial appointment or two, we were asked a series of questions and boxes were checked. But what they said, what once they were admitted to the a program, enrolled in a program, then there was no follow up. So they felt like, yes, were asked the questions, and then there was no follow up. And so when they checked in with the providers were honest. The providers did report a reluctance in asking about traumatic experiences. Many reasons were identified, but one was workload pressures. They also did talk about decreased participant engagement and then also concerns about distressing the participant. And so I think that's also then connected to a lack of brief clinical screening tools. So feeling like they didn't necessarily have maybe the knowledge, but then also the tools to be able to appropriately screen for trauma. And so we'll talk more about CAR and their colleagues and some of the things that they've done. But there has been shown to be a lack of a brief clinical screening tool. And I stress brief. There are a couple screening tools out there in regard to trauma, specifically around individuals living with schizophrenia, but it's lengthy And also, it doesn't necessarily ask about current events. So we don't want to throw away the questions asking about childhood events and family, but also individuals are still living right in real time. And so they might have had something happen to them just last week, yesterday. Also, those tools don't necessarily ask about discrimination. And then also, which I found was really relevant, psychosis related traumas. So, traumas specifically related to one's experience living with psychosis, such as hearing voices, and then also involuntary hospitalizations. It did make me think of my outpatient days, I'll be honest. And I can think of on more than one occasion doing field supervision with a case manager. And we go to the hospital, we get in the elevator, we go to the floor. Depends on the hospital. We're putting our belongings in the locker and we're buzzed in. And then we hear that door lock behind us. And that is a jarring experience just for me as a visitor. And so there is research that shows that for many individuals, the experience of being going through a process of possibly, being handcuffed, possibly being, restrained, that can then bring its own trauma response. And this is not an exhaustive list, but when we look at impact of not asking about trauma, we have seen an increase of drug misuse, suicidal ideation, and then again, a disengagement in services. And I really want to stress that this isn't about blaming providers. Again, when I think about, and I'm going to age myself, but when I was in grad school, I'm not sure we necessarily were talking about trauma in detail. Or then again, it might have been some awareness, but then also providing, students and then also individuals that are early in their career with the support and then the tools to be able to ask the questions in a way that will minimize distress. Because when asked the question, there were several participants that, gave quotes, provided statements, and this one stood out for me. I think the good ones are kind. I think they take the time to understand what you are saying and they don't rush you. They just try. Personally, I like when people ask me questions because I can go on. So I feel like when they ask the questions, they are trying to understand, they are trying to make the effort. So I really want us to think about how we can bridge the information in regards to prevalence, possible risk factors, and then how can we bridge that to action steps? Action steps are always my favorite. One of the things that we can all do, regardless of role, so again, whether we're talking about that front desk person all the way up to the CEO of the organization, we can implement trauma informed practices. These are universal practices. And again, we don't want to re traumatize anyone. So if we're all implementing just some very universal, we're all on the same page in regard to safety. Just maybe asking participants what makes them feel safe. That collaboration and mutuality, exploring values, preferences about treatment, what has been their previous experience in a treatment setting. When I think about trustworthiness and transparency, acknowledging that it does take time to build a trusting relationship. We also want to be able to empower individuals as we think about voice and choice. And we want to maintain open communication, but always want to respect boundaries and the need for privacy. I can't speak enough about peer support. So, really thinking about those peer connections, and whether that's within your organization, but if you don't have a peer support program in your org, looking outside of that organization, oftentimes those peer-led organizations and agencies do exist. And then also inquiring about community or religious support. So who are those other community members, possibly faith individuals that can support that individual, because you're there typically 9 to 5, Monday through Friday. So who are those other individuals that can pour into the participant? As we think about engagement strategies, and we are coming from a what happened to you framework, which can create an opportunity or entry point for participants. Participants oftentimes still feel a lot of shame around that experience. And so, what has been found to be successful is really looking at the whole person. So, yes, we want to create a space where individuals can feel safe, supported, to be able to kind of disclose their trauma, but we also just want to remember that participants are more than their trauma. We also want to think about and then when someone feels a bit ambivalent about treatment, that might just simply be a coping strategy. That might be a way that they are keeping themselves safe. Because in regard to power, oftentimes there was an abuse of power. And so the participant might view anyone that's holding power, even the provider, there might be a sense of mistrust. And so we really want to think about some just shared power skills such as cooperation, negotiation, dialogue, perspective taking, and compromise. So ultimately, recognizing that the participant, they hold a body of knowledge. So you hold a body of knowledge, but they do as well in regard to their shared experience, which hopefully can alleviate some mistrust and facilitate a positive therapeutic relationship. So when earlier we said one thing that might hold a provider back, a clinician back from asking about trauma is not having the necessary tools. And so the trauma and life events checklist is just a screening tool, but it was developed for improving routine screening in people with psychosis, something that is brief and that can be used in a clinical setting. And I won't go through every question on the tail, but I did want to highlight a couple. So, even like number two, again, we're not throwing away those questions because we do want to ask about like a permanent separation from someone close to you, such as a parent or a caregiver. But also, if we look at number five, we're asking about bullying or harassment at school, work, on the street. Again, that can be a very current situation. And then also, number six is asking about discrimination at school, work, or on the street. Some additional questions that stood out to me was number 17, and I will read that one to you. Contact with mental health services, for example, being admitted to the hospital, that involve threatening or upsetting events, being restrained, coerced, secluded, assaulted, forced to take medication, or witnessing such events. So, again, maybe these events didn't happen directly to the participant, but if you think about some individuals and they've had this inpatient experience, they may have been a witness to someone else having that experience. And then number 18, any other contact with health or criminal justice services, which was upsetting or frightening. So again, this is just a screen, but it can be useful when you're working with individuals living with psychosis and you want to be able to start, opening up the door for disclosure for trauma. So then you can move forward in the work. If we're thinking about diagnosis formulation, it's not always so easy to be able to recognize the symptoms and where do they fall? Did it happen in adolescence? Did it happen in early adulthood? But just to give us a foundation, I did think it was interesting when we're looking at early adulthood and having trauma experiences, exposure in early adulthood, because there is literature that shows, especially for like teenagers, young adults, like in regard to treatment, as we think about that whole person, the things that are important to them are work, school, and relationships. So when we look at early adulthood here and we see that trauma exposure that could interfere with development of intimacy and positive self-image in those particular domains. And also, as we're trying to distinguish, signs and symptoms of trauma from symptoms of psychosis, it's not always that simple because we know that one could experience flashbacks as a result of their hallucinations. or maybe there's fear and avoidance from paranoia, or disassociation from delusions. And so it's really just want that to be a collaboration, just really doing that in consultation, doing that as a collaborative decision with other members of the team. And it depends on your program. So if that differential diagnosis may or may not be as important, but again, just want to do that in collaboration with the team. You can help participants create a timeline by monitoring their stress levels, and just remembering participants, they've been going through, right? So they're, maybe they're at a point they do want to start disclosing. They don't necessarily have to elaborate on every single detail. Ultimately, we want to focus on what is the impact on the participant family and their key supporters. In regard to family and key supporter engagement, we want to try to ensure that participants have the supports they need. Yes, we want to respect confidentiality and self-determination, but we also want to have a mutual understanding on how trauma impacts the participant. So, trying to provide some education to the participant on why it can be helpful to have those key supporters involved. Also, we want to focus on or acknowledge the impacts of events on family and key supporters. So rather, they also had the same trauma exposure, or again, just have been a witness to what has happened to the participant. And as you're doing your family, psychoeducation, just really, again, anyone or most individuals are able to implement those trauma-informed principles. And so helping family to be able to implement those principles in the home and in the community. When you're looking at treatment planning and safety, again, hopefully this is a team-based planning so that if everyone's on the same page, that can help the participant feel safe and could facilitate more disclosures over time. Also, creating a space to use participants' preferred method of expression, whether that's music, art, literature. There are those peer support connections again. So really, connecting to individuals, whether that's at the organization or in the community. And then also as you're thinking about wellness planning. So the social worker in me is thinking about discharge at admission. And so just as we're planning, as we're being thoughtful about our plans, also some of that, ability, who are individuals that maybe the participant feels safe around. Also, as we think about those peer connections, who are some friends or family members that we could identify, so even through your step down planning, also wrapping that participant around those trauma informed values. And then in regard to trauma informed workplace, this can be its own didactic because trauma informed care is relational. And so, again, really want to create spaces where individuals, where you, your team members are able to do some self reflection, to be able to identify your limits, to be able to know, like, I've come this far and maybe I need somebody else to intervene. And then also creating spaces where people can take breaks when needed. I do appreciate that many workplaces are moving away from trauma informed or workplace self care and really are coming more from a collectivism perspective because we want everyone to have the supervision and support they need. Again, that on site consultation so that you and others are able to debrief after difficult conversations. And there are different versions of this technique. So I always tell people to engage as they feel comfortable. But even as I'm sitting here with you and having this conversation, some of you might feel a little activated. I know for me, I have to kind of be thoughtful and take pauses even as I'm speaking about trauma. So just maybe you're seeing something on your desk that can help ground you. This is my favorite pen I'm holding in my hand. If you're by a window, maybe you can hear traffic or even just slowing down to hear your own breath. Also, what helps me is just like feeling the clothing on my body. And again, just even in my hands, I'm holding one of my favorite stones and it has very rough edges. And again, it just keeps me grounded and centered in this moment. And one of the last things I'll leave you with is one of my favorite quotes by Hanti Roy. Another world is not only possible, she is on her way. On a quiet day, I can hear her breathing. Thank you for your time this morning.